Yeah, so thank you very much. This is a privilege for me to be speaking in this forum, and I'm speaking upon some interesting TAVR case, which a few months back I have done, and I thought it is worthwhile sharing this because there is a lot of education in this case. And our TAVR journey is becoming consolidated day by day, and our numbers are growing. So I think more the challenges which we confront during a TAVR case and we discuss amongst all of us in these forums, it's going to make us more wiser how to handle these situations for our future patients. So interesting TAVR case, and practically the interesting point in this was the coronary access and fear and scare of a coronary occlusion. So coronary artery disease and aortic stenosis, they are known to be coexisting with each other. And as per literature, the need of PCI post-TAVR, although is not very high, but it's not uncommon also. The future may look different as we now offer TAVR in low-risk cases. So what this slide means is that if we do a TAVR, and even at that point of time, patient doesn't have a coronary artery disease, we have to think that if the patient develops a future coronary artery disease, how to handle that. So this is my case. He was 56-year-old, not very old patient, but this is also one point which I like to enumerate. Normally, we consider TAVRs in above 65 years of age patients, but in some of the other patients where the morbidities are very high and surgical risk is very high, it can be thought of. This procedure can be thought in such patients also. So this was the same patient. He had many comorbidities. He had renal cell carcinoma. He had frequent urological infections. And given that, the family was very clear that they are not going for 2 surgeries because he was posted for renal cell carcinoma surgery also. And in the workup, he was found to be having a critical aortic stenosis. So we sat as a heart team, which we usually do in all cases of TAVR. So heart team decision was very clear to go ahead with TAVR. And given the age, we opted for a valve, which potentially gives the largest effective orifice area. So that was our selection. And in that, I would say without any inhibition, I think Medtronic Evolut valve is one valve which gives us a better orifice areas in terms, because it's a supraannular valve, so openings are much better as compared to all other valves available. In this patient, the critical points were a narrow sinus of Valsalva diameters, borderline left coronary artery ostia. So this is also a point which needs to be discussed in such patients. How do we plan? So this is the CT analysis. Now, if you see very clearly, so it was the sinus of Valsalva on the left side was hardly 25. So it was not a spacious anatomy. And the left coronary artery ostia, left main ostium from the annulus was 9.2. So less than 10 is a clear red flag, and we need to be extra vigilant and extra cautious if we are planning a procedure with some red flags. So these are the 2 red flags, that sinus of Valsalva was narrow and the coronary ostial height, the left main coronary ostial height was less than 10, again a red flag. All other parameters were okay, but this is a big thing. So these are the femorals, common iliacs, very spacious, no problem here. And then we went in for the procedure. As a step number 1, we do the coronary angio, obviously in more than 50 years of age. The coronary anatomy, coronary arteries were fine. There were no critical blockages in the coronaries, but as I mentioned, the main point of interest and point of concern is the red flag sign of left main coronary ostial height is narrow. And then this is how the puncture is taken. I think not a great deal. We checked from the contralateral side, do a femoral angiogram, and based on that, we see the profunda rising, and then mark up our point on the femoral head, femur head, to make a mark where to puncture, and then we go with the micro puncture, and then step up with the normal wire and a sheath. So after having done that, this is the aortogram with a pigtail catheter. See, now this also defines, if you see it very carefully, see, it's a constrained anatomy. And if you see, there's a thick valve, and valve is moving towards the left main ostium and almost reaching the height of left main ostium, covering the left main ostium. So this was the point where we were absolutely concerned that we should not be putting, making the patient vulnerable or vulnerable for coronary occlusion once we do the procedure. So I was very clear from the word go that we need to protect these coronaries. Sinus of Valsalva constrained, and a left main ostial less than 10. We need to protect. I think this is clearly written on the wall. And following that, side by side as we progressed, we crossed the aortic valve, and this is a rigid wire into the LV, confida wire. And then after this, I engaged the left main, and see a wire is into the left circumflex, and over that wire I passed a guide liner. So once a guide liner is into the circumflex over the wire, uh, I retracted the guiding into the ascending aorta. So this is one important thing. Few operators also do differently by placing a stent, by harboring a stent into the circumflex or into the LAD, and then do not take guide liner. But this is a better approach, since we are not opening any stent. We are just harboring the guide liner into the coronaries, and then proceed on with our TAVR deployment. So after having done that, so this is a Medtronic valve, and see, slowly and gradually we were opening this valve. We got a good height as regards the annulus. So we were, 3 down the annulus, and we were almost 80-90% open the valve. We are still at a point of retrieval. We can retrieve the valve still. And at this point, we waited quite patiently because there have been reports that coronary occlusions can happen even few hours after the valve deployment in TAVR. So it's not necessary that all the occlusions would happen on table. It can happen 1 hour or 2 hours after the valve deployment. So we have to be really vigilant and be safe totally, because once it happens, nobody will get a time to save a patient. So it means a life. We are practically dealing with a full life. So see, now we are constantly checking with the aortogram repeatedly whether coronaries are flowing. Our guide liner is still in position into the left main, into the circumflex, and almost waited there for 20 minutes, and checked by both means, by a aortogram and by a selective injection through that guide liner into the coronaries. So we have deployed the valve here after having established that the flow was not impeding or not a slow flow into the coronaries by both injections, by aortogram and selective injections. But despite that, we kept our guide liner even after deployment of the valve. And again, we waited for 15 to 20 minutes. I think it's worthwhile making a sure assessment of the situation, whether nothing is happening or any vulnerability for coronary occlusion. We again waited for 15-20 minutes, kept on checking with this guide liner the coronary perfusion. See, it's quite narrow actually. The margin where occlusion can happen or patient is safe is very narrow in certain patients. And this was a similar patient like this. Now, if you can see, as far as height is concerned, the native valve, which gets twisted behind this metal rim actually is almost reaching the left main ostium, but there is some extra space of that sinus oval salva which is continuing the perfusion. So, but we waited. So the reason why we waited, because even if a obstruction or a slow flow or a TB1 flow starts happening into the coronaries, we can still take a stent and make a chimney to save a patient. But if we take out this guideliner and then the obstruction starts, then the occlusion starts, then we are left with nothing. So we waited 20 minutes prior in that position where the valve was not fully deployed, and 20 minutes after, almost 40-45 minutes, even after the valve deployed, once the flow was absolutely fine, brisk, and we could actually see that that small extra space of sinus oval salva is leading to a good perfusion. Then we take out our guideliner back, and that was the end of the procedure. As far as valve was concerned, there were no gradients. The mean gradient was only 5 millimeter of mercury post valve deployment, and there was no AR. So we were pretty happy with the valve position, the outcome, and the red flag of low coronary ostial height. We took these steps to make sure that we are safe and patient is safe. So TAVR is a very powerful therapy, very patient-friendly therapy. Choosing the right candidate becomes very critical. We should clearly know the red flag signs, where to do TAVR and where not to do TAVR, or where to actually practice a special actions or special points to save and have the best outcomes with a patient who's undergoing TAVR. Keep all necessary hardware available. So this is again very important. The guideliners, the stents, the larger stent which could fit in from a left mid to chimney if required. You should have all those things in your hybrid lab. Choose a device based on a risk allowing maximum safety. In this case, a recapturable, repositionable, a biggest effective orifice area valve was chosen because patient was relatively younger and there was some risk of occlusion. So we could actually manage by keeping the valve, and once it is still not fully deployed, we can still do a lot of maneuvers to keep the patient safe. In case it is a single shot balloon mounted valve, it is done, and if occlusion happens, we can't do anything then. So this is my case. Hopefully it is going to be quite educative for the audience. Thank you very much for giving me, for inviting me here. I really enjoyed it. Thank you.